I am Dr. Ayasha Shiddika, working as a specialist, Bangladesh Specialized Hospital Limited. My topics is today pathological complete response to neoadjuvant chemotherapy in triple negative breast cancer, a single center descriptive study in cross section of population. Triple negative breast cancer, it's already has a limited roles because it is triple negative. And we all know about that issue. We oncologists are very much concerned about TNBC. In worldwide journal, it shows only 30 to 60% patient achieve pathological complete response. Why I am giving importance to pathological complete response? Because it is one of the important prognostic marker for disease-free interval, which is very important for our patients. I am grateful to my authors who helped me in this study. This is our breast tumor burden worldwide and in Bangladesh. The study was carried out in Bangladesh Specialized Hospital Limited among the patients who attended at OPD from the duration 2017 to 2022, last December. Total 2,265 patients attended Bangladesh Specialized Hospital with breast cancer. Among them, we had only 257 patients who had TNBC. It's approximately 11.35%. In international journal, it shows the range is about 10 to 20%. Among 257 patients, we had only 60 patients who got NACT. The less value due to we got rest of the patient after surgery. So we had only 60 patients with neoadjuvant chemotherapy. Among 60 patients, as this is descriptive cross-sectional study from our server data, we assessed only 41 patients with their pathological complete response. Rest 19 patients we didn't able to get their response status. We connected, but they didn't respond. So our final target population is 41 patients with neoadjuvant chemotherapy in triple negative breast cancer. This is our overall response. And among 41 patients, we had 44% with pathological complete response. This is the stage distribution among our study population. And all were stage 2 and stage 3. This is the response according to stage distribution. And most of the pathological complete response occurred in stage 2 with one stable disease in stage 3. This is the grade distribution among our study population. We didn't gather information about 5 patients about their grade. This is the response according to grade, and we all know most of the response and most of the patients were with grade 2 and grade 3. This is the response in patient who got platinum and who got without platinum. In platinum arm, there were more response, and more than 60% patient in our study population got platinum. In our study population, the patient who got neoadjuvant chemotherapy, most of the patient had common schedule, either AC followed by T or AC followed by TC, or TC followed by AC, or T followed by AC. In our population, 38 patients got conventional schedule, only 3 patients had dose-dense schedule, and all 3 of them had pathological complete response. Among our patient, 35 patients completed 8 to 12 cycles, some with 16 cycles chemotherapy before surgery. That means 35 patients completed their neoadjuvant cycle before surgery. Among them who completed neoadjuvant cycle before surgery, majority 16 out of 18 patients had pathological complete response. This is the surgical modality of our patient. In this table, I want to highlight it. We had more pathological response and more partial response, we could have more breast conservation, but it was lastly according to patient choice. So we had the final result here. At last, I want to show in our study population who had either T1 or T2 disease and either node negative or only node 1 disease had achieved pathological complete response. And in conclusion, I want to say pathological complete response can be achieved more with stage 2 disease with zero or low nodal burden. Addition of carboplatin has potentiating effects towards pathological complete response. Dose-dense schedule also contribute to pathological complete response. Total neoadjuvant therapy effective towards pathological complete response. Our limitation, because it is single center, we need multi-center involvement with more sample size and with prospective study. These are some journals. These journals published in 2023 in American Association of Cancer Research, and it shows addition of carboplatin is beneficial in TNBC. This is the Alliance trials. This also shows addition of carboplatin beneficial in TNBC. These are the journals, these are the trials which was done in neoadjuvant case with platinum, and they favors platinum. This is the journal published in 2027, which indicates in multivariate analysis, stage 3 disease was the only factor associated with low pathological complete response. This is the meta-analysis about 27 studies with 9,460 patients, and its result is pathological complete response can be achieved with platinum containing more than 6 cycle, 4 kind of drugs, more than 16 weeks treatment duration. This is the study published in American Cancer Journal in 2018, and it shows some subtypes of TNBC, and it indicates some subtype having more response and some subtype having very less response. So, what's next? As we know, after having pathological complete response or after partial response, if need, we can add capecitabine or olaparib. But what more we can do? In Createx trial, it says 70% 3 years disease-free interval with capecitabine, and in Olympia trial, it's about more than 80% disease-free interval. But what more we can do? There are some trials and some ongoing trials and some issues we can highlight for next. Thank you, BICC.